As you see, my training and background is something other than addiction medicine. That was working overseas a long time in some fascinating but difficult sometimes places to work. This talk is not about overdose prevention. The overdose has already happened. Okay, we're here dealing with what happens after the overdose. And this is to give you a broad picture of this drug. It's naloxone and Narcan. As you know, they're the same thing. It's like Kleenex and tissue paper, okay? The brand name is Narcan. The drug chemical is naloxone. I can't give you any right now because I don't have any to give you is one reason. And so this is just an instructional talk. I can give prescriptions to anybody who wants them. And we'll work on that later, okay? Unfortunately, I have no financial conflicts or interests to disclose. Yeah. The program overview, we're going to discuss, because for the training, you're supposed to go through all these things. So I'm going to go through all these things. But most of you know all this stuff anyway. It's just how the training is set up. What is an opioid? Recognizing an overdose, responding to an overdose, and tips for preventing overdoses. The laws all started in Senate Bill 523. This bill basically is called the Take-Home Naloxone Program. It has a more, it talks about a narcotic antagonist in the name. And basically, it's to allow me to give you a prescription that you can take the Narcan from the pharmacy, or if I'm going to give it to you, and you give it to somebody else. Now, the insurance companies have some trouble with that, don't they? Why should they pay for you to take a prescription for you to give to somebody else? And that's one of the problems that we're trying to deal with. So when you give it out free at a talk, that does take care of that problem. Okay. The Good Samaritan Law is next here. The Good Samaritan Law is a law that basically they tacked opiates into a Good Samaritan Law for alcohol abuse. So it's a little hard to read the bill, actually. It does give a level of protection, a level of immunity, legal immunity. If the police come in and the fire department comes in, there are a bunch of drug paraphernalia around, and you have used the naloxone appropriately, and you have saved the person's life perhaps, and you've called 911, you will have, actually, we hope, a significant degree of immunity and protection in that case. And you are required to do all that, to call 911, to stay with the patient until the ambulance shows up. That's part of the rules. This new pharmacy dispensing rule, this allows the pharmacist, you can go up to the pharmacy, ask for Narcan, they will sell it, they will give it to you, but they will sell it to you. They don't pay for it. Okay? If you have Medicaid, it's a $3 copay, but a physician has to sign the prescription. So it really doesn't do a lot of good. And if you ask for Evzio, the injection stuff that I'll show you later, that's $4,000 you got to pay for. So I'm not sure exactly what this is. The other possible issue with this is that the demographic data, your age, date of birth, where you live, etc., will be included in West Virginia's Controlled Substance Monitoring. I'm sorry, what are we doing here? Controlled Substance Monitoring Program. I'm not happy about that, but I didn't write the law, so I won't comment on it too much. Why controlled substance monitoring programs, which record prescriptions for narcotics and stuff, why we're putting Narcan in there, I have no idea. It's some data capture stuff, but I'm not happy with that. I do not give that information to the Controlled Substance Monitoring Program. I keep it in my own files. And the people who want access to that database, police departments, do have access to it. So I think there's a medical confidentiality issue there. No one's interested in my opinion on that. Okay, this is Las Vegas. I hope what happens in Las Vegas doesn't stay in Las Vegas. This is Narcan, naloxone, given out in a vending machine. Later they're going to be giving out pregnancy tests, needles and syringes. You start on this by going to your harm reduction group, registering with them, and they give you a magnetic card. And then you go get this stuff. If you try to get 8 or 10 of them one day, no, the card won't let you do that. It's very well controlled. It sounds fantastic. But again, maybe it'll stay in Vegas, I hope not. Opioids, any drug that contains opium or its derivatives. Sorry here. I forgot to reset this timer. Okay. Natural or synthetic, prescription medications or illegal drugs, pill, capsule, powder, liquid, swallowed, drunk, smoked, snorted, injected, transcutaneous, all sorts of stuff, any way you do it. When my father was a little baby in India, his parents were missionaries, Methodist missionaries. If you had teething problem, the IE, or my grandmother, I guess, would scrape her fingernail across an opiate block and rub it on the gums to help the teething pain. Okay, this was my father was born in 1913, so you can do the arithmetic. All of these are different, and all of them are similar. They all approach the same mu receptors in the brain. They all add up together. If you take a whole bunch of them together, they'll all do the same damage, just more of it. So that particular way it's absorbed, the type of drug it is, will determine how quickly and powerful the drug acts, how long the effects of the drug last, how quickly you become addicted to it. That's very important. And how great is the risk of overdose. Opioids manage pain, suppress coughs, treat opiate use disorders. The two main drugs we use to treat addiction are both opioids. Okay? And the effects last from 3 to 24 hours, sometimes longer, some of these drugs. In excessive amounts, they stop a person from breathing. Actually, opiates don't do a lot more than that. They don't affect your lungs or your heart or your muscles. They don't affect most of your brain, just the addictive pathways in the brain. They don't do a lot, but what they do does a lot of harm. They come in many forms. I put this as a placeholder because when I first gave this talk to a bunch of my patients in the clinic I was working in, they asked me, please, Dr. Ellis, do not show those pictures again. These are my patients, okay? That was a select group, but the pictures were simply too upsetting. They showed the usual guy laying on the floor in the bathroom in sheets with the needle hanging out of his arm, and they showed the needles and syringes, and you all know what that looks like anyway, but my patients asked me not to, and out of respect for them, I decided I wouldn't. So any narcotic can cause an overdose if you take enough of it. And then we have the reminders from the past. Here we have alcohol, cannabis, chloroform, morphine for cough syrup. And here we have heroin hydrochloride. Bayer, the Germans did a job on us. They did a job on us. They invented all sorts of evil stuff. And then we have aspirin, heroin. Okay. And here we have, this is a classic. I wish I could get one of these bottles. Oh, God, it's beautiful. And here we have the little kid reaching for the cough syrup, which is morphine. And I put the cocaine toothache drops because I just couldn't. It's so beautiful. It's not cocaine. It's not morphine. And this one I just found, glycoheroin. Heroin was invented, discovered, first manufactured by the Germans, by Bayer in 1874. 10 years later, 20 years later, they started to market it. And then they found if they mixed it with glycerin, it tasted better. Thus, we have glycoheroin. And if you read the small print, and it's really small, it does just about everything you'd want an opiate to do for you. So what's naloxone? It reverses an opioid overdose by restoring breathing. No potential for abuse. You never get high on it. It has no effect on somebody who hasn't taken opioids. One of these days, if I give a talk to a whole bunch of people, I'm going to dose myself with Narcan during the talk to make the point. It doesn't do anything. Okay? And it's perfectly safe, unless you are addicted to an opioid. The side effects are minimal and rare. It's safe for children and pregnant women. Intramuscular, intravenous, subcutaneous, or intranasal. It wears off in 30 to 90 minutes. It's only effective in opioid overdoses. If you have a bunch of other stuff on board, benzodiazepines, alcohol, whatever, it's not going to help you with that, but it'll help you with the opioid component of what you've been taking. So how does it come? Well, you have the needles and syringes, and we talk about this often, the needles and syringes. I personally, and my patients I talked to, were uncomfortable about giving needles and syringes out to patients to put on their kitchen cabinet counter. I don't see the point to that, okay? And my patients didn't see the point to that. This is a popular product with the first responder groups, okay, the fire departments, the police departments, and we'll talk a lot about more. This is the same stuff, and we'll talk a bit more about that. This is FZO. FZO we'll talk a little bit more about too. This one is nasal. I'm sorry. This one is nasal. This one is injectable. This is the same thing. And this was an injection. And I'll show you an example of that here. And this is my favorite, okay? Narcan nasal spray. It's dosed better. It is a remarkably good drug, okay? It's also a higher dose than some of the other things that are out there. It's higher than the Amphastar product. It's 10 times higher than the original FZO, 10 times higher than the original FZO. So how does it work? Well, here you have the evil opioid molecule sitting on the mu receptor, okay? And they sit there and they hang on pretty tight. And if enough of them go onto enough of the mu receptors, you feel good and you stop breathing, okay? That's the risk of it. So what you need to do is get something to come along and sit on that mu receptor instead of the opioid, and it'll keep the opioid from landing on it. And that's where naloxone comes in. It sits on the receptor. The problem is it gets eventually washed off the receptor, just like the opiates do. Okay, and so that's why eventually you just can't be on this stuff forever. You eventually have to either stop using the opiates or go to a different drug. This is the product, as I say, that the first responders like. If you notice, this may surprise some people, and I'm sorry if it does. Intravenous, intramuscular, subcutaneous. Did you see intranasal in there anywhere? I didn't see intranasal in there. The FDA didn't see intranasal in there either. The FDA has not approved it for intranasal use. And the reason is because when it's prescribed, you have to have one of these things, a nasal atomizer. But the FDA hasn't approved it for intranasal use, so the FDA will not allow that to be approved by the FDA. Now, if a person is properly trained how to use it, this procedure, I don't care how the Narcan gets in there, okay? If it's the Amphastar product or the FZO product or the Narcan, I don't care, okay? But the problem is the FDA cares that if a group of people here get a class and a year later they want to give this stuff, how much of this are they going to remember? The FDA is for safety and efficacy. Both of these things are of concern to the FDA, and this goes against them. So FZO, FZO, God, I hate this stuff. Okay, this is FZO.
This trainer contains no needle or drug.
I'm not making this up. Okay.
If you are ready to use, pull off red to inject. Place black end against 5, 4, 3, 2, 1.
You gotta love it.
Complete.
Okay. So we say, why don't we just do this for everyone? And the
This
FDA.
trainer may be
Oh, shut up. The FDA approved this. They approved the first version of it was 0.4 milligrams. It was a tenth the dose of the Narcan nasal spray. It was a while ago. Okay. Then FZO came out with a new product, but the ones you see that were given out free for a long time were this extremely low dose version. Okay. And of course, at $4,000, they're getting a major tax write-off because that's it. This is Walmart and Sam's Club. This is a local website. It's very expensive. So they get a major tax write-off by doing it. In fact, if you go to a lot of talks, you will be given FZO as one of the things. I just would suggest if you do, make sure you're getting the higher dosed FZO rather than the cheap dose FZO. For some reason, the price didn't change. I could not find where the price changed. You can't find on the website very easily they have two doses. It's very difficult to find. I looked really hard. And here's my favorite again. Narcan nasal spray, 4 milligrams a shot, a dose, one of these things, but 2 of these come in each box. So it's 8 milligrams total. All naloxone comes as 2-dose packs. It's just the way it's done. It's simpler to use. It's a higher dose to reflect the fentanyl problem that we're dealing with. And the really good news is $3 copay for Medicaid. That's almost like free. That's like what, one-fourth of a pack of cigarettes, I think. Okay, Medicaid is supporting this very well. Okay, and I'm really happy to hear that. So you give the full content in one nostril and repeat it in the other, and I'll show you the details of that later. I will say, Have you ever seen the movies where the doctor shoots some of the stuff up in the air from a syringe and then wipes the needle off with his fingers? Yeah, you don't do that with this. This is 1/10 of a milliliter, the dose. That is 1/25 of a cc, of a teaspoonful, 1/25 of a teaspoonful. So you don't test it first, okay? Please, because the whole dose will be just wasted then. Storage and disposal is not unlike many other medications. You go ahead and avoid excessive exposure to light. Keep in they say room temperature. I know many of the police departments store the stuff in their glove compartment in their cars. Can't recommend that, except that's very common, keeping it in the car that way. It loses its effectiveness over time. It does not become dangerous. It just becomes less effective. Okay, this is kind of off-label here. If it's all you got, use it, because you're not going to hurt the person any. Okay, so, but if you notice the date's gone on it, just come to somebody to write a prescription. I'll help you out. Okay, this is I just made this one up yesterday. This is the original FZO, 0.8 milligrams a dose. Actually, that's not true. It's 0.8 milligrams a prescription. That's 2 doses. Everything's here 2 doses. This is the new one. They upped it a bit. It's 4 milligrams. Okay. And then the Amphastar product is also 4 milligrams. This is the one that the first responders like. And then we have Narcan nasal spray, which is 8 milligrams. And if you notice here, how much does something cost? Okay, if you buy FZO in the pharmacy, it's $4,000. If you get it free in a talk, it's 0. So the cost is somewhere between $0 and $4,000. What does that mean? Okay, so I did the best I could to find out the costs. And the Amphastar product is about $132, and the Narcan nasal spray is about $130. Don't forget, with the Amphastar product, you got to pay separate, if you can get them, for the atomizer. Again, I keep making strikes on the Amphastar product because I think the Narcan nasal spray is a better choice. Recognizing an overdose. Well, how many of you have seen an overdose? Wow. Brent hold his hand up. No. That's good. I like an audience like this. An overdose happens obviously when the amount of opioid or alone or mixed with other drugs overwhelms the body's ability to handle it. Many opioid-related overdoses result from mixing painkillers, different kinds of narcotic painkillers, with heroin or benzos or cocaine or alcohol. What leads to the overdose? You have respiratory failure. The vital organs like the heart and stuff, they do fail. I said the opioids didn't affect the heart and stuff, but they're not getting any oxygen. They're going to quit. Okay, they do start to fail. And this leads to unconsciousness, coma, serious brain deaths, damage, and death. The whole key is get oxygen in the blood to get oxygen to the brain to keep the person alive. There are 2 or 3 ways to do this. One, get them breathing on their own with some naloxone. That works pretty well. The other is to go ahead and breathe for them, and we'll go into some little details on that. How many of you have had CPR? The CPR you had, did they teach you mouth-to-mouth resuscitation? Thank God, because the American Heart Association has quit doing that. Now they're recommending hands-only CPR, which purpose of CPR by American Heart Association is to keep your heart beating. Okay, that's not what we're working on here. Here we're working on getting air and oxygen into your lungs. It's a different situation. You do all this before the person dies. The signs and symptoms: loud snoring, gurgling, death rattle, body very limp and responsive, blue, pale, slow pulse or erratic. My advice, don't try to feel the pulse. With an opioid overdose, it doesn't matter whether you do or you don't feel the pulse. You're going to do the same thing anyway. Okay? If you're lucky enough to feel a pulse, you don't have to worry about it. If you can't feel a pulse, it's probably because you can't feel a pulse. So the point of an opioid overdose is treat the respiratory failure. Breathing very slow, shallow, not at all, or unconscious. Remember, you will never do any harm by giving the naloxone. You'll do the harm by not giving the naloxone. You act on the basis of apnea, the person not breathing. The exact diagnosis isn't particularly important. If they're not breathing, treat it like they've got to be breathing. And 2 ways to do that again: naloxone to deal with the opioid overdose, or artificial respirations. Okay, what's the first thing you do? Rouse and stimulate. CPR time. Annie, wake up, Annie, okay? What's the second thing you do? Now, you know you have a desperate situation here. You got a guy that's dead laying on the floor in front of you. What are you going to do next? What do you do if you have a really, really sick person in your house? 911. Thank you. And that is the next step. Perhaps the most important point of this whole talk, that just giving the naloxone itself is not the way you handle an overdose. If you see a desperate situation, call 911, okay? And better, have someone else do it for you. That's much better, okay? And then you initiate rescue breathing. I'm going to do some details on that later, okay? Because you want to make sure that the airway is patent, it's open, before you give the Narcan. What if they have a big wad of chewing tobacco back in the back of their throat there, and you give them Narcan, they still can't breathe. It doesn't matter whether they're trying to breathe or not. So initiate rescue breathing, administer Narcan, naloxone, and care for the person who help arrives. Again, this is the Good Samaritan law. You got to do this, okay? Annie, are you okay? If no answer, you do a sternal rub. Now, be pretty rigorous in trying to wake them up, okay? I'll show you something here later. The point is to try to wake up the person and determine their level of consciousness. You're trying to make them hurt, but you're not trying to do them harm, okay? Got to make them hurt, because that's, you determine this person is a, what is it, Brandon, a stage 4 coma scale? Anyway, well, you're dead. You're clinically dead, okay? I like this picture because the person's on the ground, acting like they're not breathing. He's not blue enough, of course. At least he does have some bruising over the veins of his antecubital space there, so maybe he's a overdose. He's not blue. This is the dumbest picture I can show you. Why you would do a person sitting in a chair, I have no idea. And this is cool. And it's a little bit serious. If a person is actually taking a nap and you pounce on them with a sternal rub, you're not going to be very popular. And then we have a word from Dos Equis. I don't always wake up sleeping children, but when I do, I go directly to the sternal rub. You get emergency help. The reason you do this for a whole bunch of reasons. And again, this is important, okay? They may have something, maybe they hit their head on the pavement, on the concrete, and they're unconscious from that, okay? Maybe they've had a heart attack, and that's all they've had. The naloxone is only temporary. It lasts 30 to, it said 90, I'm not sure I agree with that, but it doesn't last very long. They may need more naloxone than they have. Maybe you have 2 doses and the person needs 5 or 6 or 7 doses. You can't overdose. You essentially can't overdose on this stuff, okay? It may be a non-opioid overdose with all the other stuff they can be taking. It does provide limited immunity to people who call and follow the rules. Most important, in my mind, I think Brant's mind too, it may lead the person toward treatment. Okay? If you don't call, they're not going to go into treatment. Okay? So you get them into Brant's place, and Brant knows how to slide them into a treatment program. You all know Brant, don't you? Yeah. Brant is the emergency room doctor here at the hospital here. He is the expert. He should be giving this talk. Okay. If possible, have someone else call. You tell the operator who you are, mostly where you are, and you observe, I think the person's had an overdose. You tell the emergency responder, you think when they show up, the substances they may have used. Rescue breathing is the quickest way to get oxygen into the body, and one of the most important things you can do to prevent someone from dying of an overdose. Modern CPR does not usually, although it goes back and forth in England and America and everybody else doing it differently, it does not usually teach rescue breathing, and preferably CPR now is being taught as hands only. You're punching on the chest to get air into the lungs. While you're punching on the chest, you're squeezing the heart. You're not really squeezing the lungs very well. Okay? So, and that's what they say. So, okay, you've seen this if you've had CPR. It's head tilt, chin lift. You're trying to open up right here, the airway. And if you see a big wad of tobacco, put your fingers in there and move it out. Okay? Again, modern American Heart Association CPR does not teach that necessarily, but I'm not teaching a heart attack case here. Okay? This patient presumably will be extremely relaxed. He's not going to bite you. If he can bite you, he can probably breathe. So look, listen, and feel. Again, I understand modern CPR does not teach this, but you put your ear down on the person's mouth and nose. You watch the chest. If they're going, they're not breathing. Okay? They got to be this. You see that by looking, and you got to hear and you got to feel the air. Then you know they're moving air in and out. If they are, and they're on a downward trajectory, it's probably okay to use the Narcan. Or wait until they actually do stop breathing altogether. My general sense of advice to you was, if you know they're breathing, getting air in and out, maybe don't give the Narcan quite yet, but get it available. You pinch the person's nose completely. You all know why, right? And then you cover your mouth, that person's mouth with your mouth, about 2 regular breaths. Now, this is just checking to make sure the airway's okay. This is not respiration yet. This is make sure air will go into the chest and come out of the chest. Okay. After assuming the airway's patent, then you give the Narcan. Okay. And you give 1 breath every 5 seconds, 12 breaths a minute. Don't go your whole lung completely full and force it in there. Just do a fairly regular breath. And regular chest compressions I have to put that in there because that's the current training from American Heart Association. Okay, now let's take a pause here. Okay, I'd like to look at this in an older perspective. God did blow into Adam's nostrils, but we can give him a pass on that, okay? By the 9th century BC, Elisha, a disciple to the prophet Elijah, Book of Kings 2, chapter 4, there appears to have gotten it right with mouth-to-mouth resuscitation. He does a remarkably good job of it. This is from a JAMA article, Journal of the American Medical Association. I can't make this stuff up. This breath of life, though, is a theme throughout literature, through the scriptures. You're actually bringing a person alive by doing this. And when you've done it, that's what you feel you've done. So you allow 3 to 5 minutes for the dose of naloxone to work. You continue rescue breathing as necessary. I'm not telling you guys, by the way, to all use mouth-to-mouth resuscitation. Please believe me on that, okay? I had a patient who, no, actually she was one of the people at one of my talks, and the father of one of her daughters, the guy overdosed in their driveway in his car, and they managed to resuscitate him with the Narcan, pumping on his chest. She described this guy, and she didn't want to do mouth-to-mouth resuscitation on this guy at all, and she didn't. But then about 3 months later, she came to me. She said, Dr. Aldous, something funny happened. My daughter collapsed in the living room a couple weeks ago, and I did mouth-to-mouth resuscitation. And those are the kind of decisions you have to make with every single patient. You make the decision yourself. You do the best you can. No one is telling you that the only way to do this is mouth-to-mouth resuscitation. I'm not saying that. If breathing is not restored, give another dose of naloxone. Continue rescue breathing as necessary. Stay with the person. Provide care as directed until medical help arrives. Continue rescue breathing. Do you see a theme here? Yeah. Okay. This is the little gadget right here. You push it in, and I have not given this to anybody yet. But when you push it in gradually, evenly, slowly, all the way to the bottom. You don't quickly squirt it. You take your time doing it because it has to atomize. There's a little bit of resistance to it. Don't test it to make sure it's open. Please don't do that. That's the whole dose. I'm sorry, I said a 25th. It's a 50th of a teaspoon. 50th of a teaspoon. It's like 2 large drops. 2 large drops. Now we'll see if we can make this work here, okay? Okay. And I want to do this because this is actually produced by...
Narcan nasal spray is not a substitute for emergency medical care. As with any drug, we need to be aware of important safety information concerning its use. Please see indication. Because prolonged respiratory depression may result in damage to the central nervous system or even death. Lay the person on their back to receive a dose of Narcan nasal spray. Remove Narcan nasal spray from the box. Peel back the tab with a circle to open it. Remove and review the printed quick start guide inside the package. Hold the Narcan nasal spray with your thumb on the bottom of the plunger and your first and middle fingers on either side of the nozzle. Do not press the plunger to test or prime the device. If you do, you will waste all or part of the dose of medication. Tilt the person's head back and provide support under the neck with your hand. Gently insert the tip of the nozzle into one nostril until your fingers on either side of the nozzle are against the person's nose. Press the plunger firmly to get the full dose of Narcan nasal spray. Remove the device from the nostril after giving the dose. After you have given this medication, seek emergency help right away. Narcan nasal spray is not a substitute for emergency medical care.
Somebody to stop breathing. I think they had an overdose.
Move the person on their side after giving Narcan nasal spray. If possible, put their hands under their head and bend their upper leg forward. This helps prevent the person from rolling onto their stomach. This is known as the recovery position.
So stay with the person until help arrives for the reasons that we've given you there. Keep the person calm, encourage him not to use drugs anymore. I left that in from the old slides. And if overdose symptoms return, give another dose of Narcan. If you have to leave the person, you go into the recovery position. There's a video on this too, a very short one. I won't bother showing it, but the point is that you do it the way she showed you there in the video. You have their leg, you have their hand supported here, so this makes this airway a bit straighter. You have this leg bent like this to keep them from rolling over. You don't want them laying on their back any more than they have to, because if they vomit, then it's all going to go into the lungs. And so that's a fairly important rescue position. And don't do any of this stuff. Cool the person down in ice water, slapping them, burning them, salt water injections. Yeah, that's all been done. That's actually a list of stuff they found. Okay, so now we have AEDs around. When my wife goes to the gym and she sees this every day. Okay, and we do have a place to call 911. But where's the Narcan kit? How often have you seen a Narcan kit on the wall someplace? You see AEDs on the wall, 460 joules of electricity slashing through your chest. That's okay. You don't need to be a doctor to do that. Yeah, it's crazy. We should be having Narcan a lot more available than we do. Where to put it? Your kitchen cabinet, your purse, your car, your schools, shopping malls, gas stations, motels. A lot of companies will not allow their employees, even if they're trained to use this stuff, to use Narcan. If they're an employee working in a gas station or grocery store, it's against the law. I get news sent like that commonly. We should inundate the community with this stuff. So I'm going to give you a certificate to document you were here, a prescription for, if anybody wants a prescription form, I'll give them a prescription from here. Okay, if you have Medicaid, this cost me $56 copay on Blue Cross Blue Shield. So again, someone asked how much does it cost? That depends on your insurance. If you're lucky and you have Medicaid, you get it for $3. If you have Blue Cross Blue Shield, federal employee, $56. For my wife, it was $75. I guess I shouldn't complain. And I do need some information filled out. If I give you a prescription, I want you to put your name, certificate of attendance, I want your name. I already put the date in there. You just take this home with you. If you get a prescription, I want your name, your gender, your date of birth, address, and date. This is the same thing you'd do if you went to a doctor's office, okay? Except that he'd probably be kind enough, or the nurse, to fill out most of this up here. You fill it out yourself. I filled out the rest of the bottom, and then I'll sign it. I do need this information, however. Okay, and I keep this myself. This is totally confidential. It goes nowhere. But I need some record of having seen you and a little bit of demographic information. And I need to know if you're your initial responder, ambulance driver, whatever, an individual at risk, that is, you are using drugs, are you a relative, friend, or caregiver, or somebody who might overdose. That's required information by the taken naloxone law that got written. And I can send summary data of that to the state. Only summary data, no names, no identifying information. So that's the new group there that I just showed you. Most of you are either a 3, 4, or 5. You're either a relative, a friend, or a caregiver, or somebody in a position to assist. If you do use this, or you know someone who does, please let me know personally. If you don't mind, I'd like to know that. But you also have one of these forms included in the kit with a prescription. Okay? The overdose prevention tips, I won't go over these very much. They're pretty obvious. You don't take too much of a narcotic. You don't take 2 or 3 narcotics at the same time. You don't use your friend's narcotics. And you don't mix narcotics with other drugs that you think might be very, very safe. They may not be with a narcotic. Some special groups, parents, families, patients, anyone who's receiving the opioid analgesic. Don't forget, we got the kids around there too, okay? Eating their grandma's pills. Patients receiving treatment for addiction. All the addiction clinics should be getting this talk and should be getting Narcan to take home with them. Jails and prisons upon release, why not? Discharge from emergency medical. Did you guys give out Narcan, Brent?
No, we tried to make that happen, and it's just not, it's very difficult to make it happen.
Yeah.
For reasons I'm not going to try and explain, but
Yeah.
we tried to.
Okay.
Yeah.
Again, with this stuff, the training requirement really isn't there. I'm giving this talk anyway. But the training,
Not at all.
no,
I take medication for a physical ailment I have, and my doctor pretty much said, well, if this is what you're taking, you have to have this at home. No schooling, no education, just have it at home. I said, well, what good does that do if I don't know how to use it, you know?
well, you should actually, the package insert is really pretty good. And
Well, but it says on the box, don't open it.
Open it.
But I was glad to get
It
your
is pretty good.
seminar.
That video I just showed, Narcan insists you do not need formal training for this. That's why the FDA approved it.
Yeah, but any kind of training is good. I mean, that's
Yeah.
why she and I are here.
Yeah, I like you guys to get the attitude about Narcan too, not just how to use it. That is, I'll show you here. So motel owners, detox, treatment facilities, all of those. So more groups, needle exchange people, harm reduction, persons who use heroin, obviously schools. Talk to your friends, please. Encourage participation for the local pharmacies. Encourage anyone you know who may be in a position to use it. Schedule, set up another Narcan talk, and make Narcan nasal spray available for people who are giving classes. Me, for example, so that I can give this to you. Berkeley County Recovery Resource Center, they actually give this stuff out. Big surprise. So that's great. You can go there, hear another talk, and get the Narcan nasal spray. The other 2 health departments, they give Narcan out when they can get it. The biggest risk for Narcan is when it's not available or not being used in a timely manner. That's the biggest risk. If you think you need it, you shouldn't use it because you're not going to do harm, and you will do harm if you don't get it in many cases. People who might need it should have it available immediately, and more funding is needed for distribution of Narcan. Okay, it's hard to find an amusing thing to end a talk like this on, but I thought that was pretty good. And then we have, and then we have the Affordable Care Act, solving the problems. Okay, that's it. You can have that slide. Okay, questions first.